He is an operated case of both bone forearm fracture. 10 nails were inserted. So today he's posted for implant removal. Dr. Sandeep Devan sir will be doing the suit scan, sequential ultrasound imaging technique for the brachial plexus, and he will demonstrate the supraclavicular block for this patient.
And I'm now going to go shift the probe a bit more caudal. You will see some hypoechoic shadows in the investing layer of deep cervical fascia. So this entire is the deep cervical investing layer of deep cervical fascia. Just follow some hypoechoic shadows as they emerge and they move into the subcutaneous tissue.
Can we have the ultrasound screen?
There's no ultrasound screen, huh?
Yeah, we are able to see, sir. Again.
Okay, yeah. So you will see some hypoechoic shadows in the investing layer of deep cervical fascia. Neeta is demonstrating that. And you will see some of these shadows which emerge from the investing layer and they exit into the subcutaneous tissue. Yes, those, and they will form the supraclavicular nerves. So these small hypoechoic shadows, what you see are the supraclavicular nerves, all those. And as we come more low down, you can see again we focus on the cervical rami. You will see the C5, then you will see the C6, that's the tubercle, that's the anterior one. Then you have the C7, which will have just the anterior tubercle and there will be no posterior tubercle. The posterior tubercle and no anterior tubercle, and you will have the vertebral artery. If you have a color, we can have the vertebral artery, which is close to the C7 rami. So that would be the vertebral artery. And as we go more caudal, you can see that the interscalene, the trunks are sandwiched between the anterior scalene and the middle scalene. To the left is the middle scalene, to the right is the anterior scalene. And you'll have to watch the phrenic nerve which courses on the top of the anterior scalene muscle as a hypoechoic shadow as it runs more medially as you descend, and then it disappears. But then you'll have the divisions now, the supraclavicular divisions which are coming up. Superior trunk formed by the C5 and C6. So that is the C5 and C6 forming the superior trunk. You can also see the long thoracic nerve in the middle scalene muscle. And as you come more low down, the middle trunk is formed by the C7. You start seeing the C8 and T1, not very clearly seen here, but you will find those at the corner pocket, which is formed by the rib and the subclavian artery. Now, here below, here as I move more caudal, you can see the omohyoid muscle right on the top, and the entire brachial plexus would lie below the omohyoid. As I move a bit more cranial, you will see a small hypoechoic shadow arising. That's the supraclavicular nerve. Now watch this supraclavicular nerve as it moves into the C5 and C6, and then it drops into the superior trunk. And when I come caudal, it moves away from the superior trunk and then forms the suprascapular nerve, which is just below the omohyoid. So this is the point where you have the supraclavicular nerve, the posterior and the anterior divisions, which form a part of the SPA, that is the SPA. A small needle insertion. I'll have to tell this patient who is awake. A small needle insertion. एक सुई चुभेगी आपको. So these needles, again, as I mentioned, they are very blunt. You have to be very careful about these needles. So this is the needle. You can see the serrations, and I need to go a bit more caudal here. So I need to direct it more superficial and caudal. So that is the needle tip, which I can see now it's close to the omohyoid. It will pierce the omohyoid muscle, and it has to go beyond the omohyoid. So it's going more caudal, just below the omoid. Yeah, can you inject, please? So we'll try and see whether we are below the. Wait, 1 minute, 1 minute. So I think more feasible would be this. So I place the needle tip a bit more of cephalad, just below the omoid. You will always feel a small pop. You could feel a small pop there. Yeah, injects very slowly, very slow. Yeah, can you inject small volume? So it is just going below the omoid. You can see the brachial plexus moving away. So this is a sort of extrafacial injection. It's not intrafacial. I have to pierce one more sheath here. As you can see, there's one more sheath between the suprascapular nerve here and the posterior divisions here. Towards the medial side, a small pop, and this would be intrafacial. Yeah, can you inject, please? Small volume. Yeah, keep on injecting. You can see the second sheath which is lifting up. So that.
Yes, we can.
So that is the second sheath which is being lifted up. So we had two sheaths. One was the extrafascicular, and now this is intrafascicular. You can see the brachial plexus elements being now separated. You can see the supraclavicular nerve, suprascapular nerve, which you can see now is engulfed with local anesthetic. As the drug spreads, Neeta injects, the drug spreads more towards the posterior and the anterior divisions. So the entire, now the brachial plexus here at the level of the superior trunk is engulfed. This is the needle tip. She has given, she has given just hardly 5 ml of local. Now I am proceeding, I have got a space here, so I am proceeding through this space towards the, supposedly the corner pocket here. I have to be very cautious. Can you increase the depth a bit? Yeah. So this is the corner pocket. The tip is very close to the corner pocket. I will request her to inject a small volume. Wait. Yeah, now. So you can see the spread is close to the corner pocket. Yes, that's the needle tip there, almost at the corner pocket. Yeah, keep on injecting a small volume. Yeah. So that is going to take care of the C8 and T1. So this is the spread in the corner pocket. That's the needle tip. What you can see is the needle tip. You can still go a bit more further. Yeah, that should be fine. Yeah, inject please. So that will help in the blockade of the C8 and T1. So you have the superior trunk, you have the inferior trunk. Now remains is the middle trunk. So this is the middle trunk. You can see the components of the middle trunk. So just at the lateral border, you don't have to go right inside. Yeah, small volume. Yes. Can you see how it dissects from the fascia? So that should be the way the brachial plexus blocks should be given. This is again just engulfing the superior trunk. You can advance your needle a bit here at this point. Yeah, inject please. Yes, and then even go towards the corner pocket. Now this makes a space for us to go towards the corner pocket. I'm advancing the needle tip. Yeah, that's all. Yeah, that should be fine. So the entire brachial plexus can be covered in a very sequential manner. Now if you can go from the caudal to cephalad, you can see the supraclavicular nerve. You can see the posterior and anterior divisions. You can see the middle trunk very well engulfed in the local anesthetic. The inferior trunk had already been blocked. You have to just see the spread, whether the spread is going more cephalad. There is a small spread in the interscalene area, but there is no spread beyond that. Yeah, it goes up to the level of interscalene, but not up to the level of C5 and C6. So this is how you need to do a supraclavicular brachial plexus. So this was the truncal blockade along with the corner pocket injection. Yeah.
Any questions on this up to now?
So that's it. We go on to the last block. That's the pudendal nerve block. We have to finish it before 12:30. Devesh, questions can be asked later on.
Yeah.
We'll shift this patient. Thank you very much, the team, entire team. So I congratulate Dr. Anshuman and his